All. This is Dr. Mobeen Sayed from drbeen.com. Welcome to one more show. Today we are going to talk about Moderna's assessment by FDA. We are expecting that by tomorrow or maybe by Friday, we will have an approval for Moderna's vaccine as well, and Moderna would start then preparing for inoculations. So I wanted to go over the FDA's document with you. This is a similar document as we went over for Pfizer as well. So let us start this. Some of the things that I can recall from reading the document are the following. Number one, the efficacy is really good, 94.5%. Number two, the efficacy was equal almost in all subgroups. That means Hispanics or Black folks or Asians or others. So that is an interesting thing. Then there was no death due to severe COVID in Moderna's arm versus there were deaths from severe COVID in placebo arm. Although Moderna says that after the cutoff date for the data collection or for data submission, they are of course still collecting data and they'll continue to collect data. They did have one case of severe COVID death that might become part of the vaccinated group data. So they are still working on it and they would update the data afterwards. The other interesting thing that struck me when I was reading this document is that most of the adverse effects were like pain or fatigue or myalgias, but most common was pain. The fever and myalgia was also part of the adverse effects. Most of those occurred in the age group between 18 to 65. Folks who were above 65 years of age, they had lesser adverse reactions, which tells me that possibly because their immune system is not as aggressive, they were not reacting as much. So the younger age group had, or relatively younger age group had more adverse reactions. And once again, most common adverse reaction, fever and or pain, most of the adverse reactions, they stayed for a couple of days and then they subsided. At least in this document, I have not seen any adverse reaction like anaphylactoid reaction or anaphylactic reaction. There is a section that we will look at today, which is within 30 adverse reaction within 30 minutes of the injection. So if there is an anaphylactoid or anaphylactic reaction, it should occur immediately, and there is none, even none after that as well. Another thing that struck me was that the one dose protection after one dose was not sufficient. So that is a similar thing that with Pfizer as well, protection after one dose was not sufficient. So one dose is not sufficient. And you would look at the data that there were some people who received one dose and then did not go for the second dose. And there the protection was not sufficient. This is also an interesting point because if we say for some reason that vaccine is really not doing much, then you can actually see that after one dose only, there are more infections in the vaccinated group versus those who got the two doses, and then the number of infections are very few. Severe cases are almost very few as well, and then deaths are none in Moderna's group. So these were interesting. What is missing in this? Let me back up for a second. They had talked about patients of HIV and their vaccination. They have talked about people who may have had the SARS-CoV-2 before and were vaccinated again. They say that the data is small, but still it seems like vaccine protects them from a reinfection because in the placebo group, there was a reinfection encountered. They do not have sufficient data about pregnant women. Although in this study, during this study, there was a spontaneous abortion and there was an elective abortion, but both of those occurred in the placebo group. So this is the general lay of the land with Moderna that I saw. So what I'm going to do is a couple of things. One, I want to right in the beginning discuss if fetal tissue is involved or not. My basic answer, let me just keep spilling the beans. So if you just wanted to hear the first part and then go, you can. Moderna's vaccine and Pfizer's vaccine, BioNTech vaccine, are not built in the fetal tissue. They do not use the fetal tissue as the factories or the fetal tissue cells as the factories. And I want to qualify this one more time that these cells are the copies of the cells of the fetal tissue that was taken in 1970s. So these are copies of those cells. These are not those cells exactly, but still they are their clones. They are their copies. Moderna and Pfizer are both messenger RNA based vaccines. They are not manufactured using fetal tissue, although Moderna was designed. So when the scientists were trying to design the vaccine, what they wanted to do was they take a messenger RNA's piece from the SARS-CoV-2 and then inject that into various cells to see if they will make spike proteins or not. So they wanted to confirm that the genetic code that they have taken is going to make the spike protein. So for that, during the design process, they had taken the messenger RNA's piece, the genetic code for spike protein, injected that into, I believe, HEK 390 or what, 293, and then they saw the spike proteins generated. So that was that much of their usage of the fetal tissue to design or take the part of messenger RNA. Then once they had decided that this is the messenger RNA that is needed, then further on, there was no fetal tissue used. Neither is there any fetal tissue in the final vaccine at all. It's not even purified from the fetal tissue like AstraZeneca. It is made totally separately. So in that on that point, I would also discuss the composition of the Moderna's vaccine as well, just like we did that for Pfizer as well. So this is the basic gist of the lecture today, or the talk today. Lots of data to look at, so it might become a little long, but the general outcome is what I have just discussed with you. So let's start. Before that, how is everyone doing? Are you ready for a long discussion of the document itself? And Gregory, you're correct. So Janet, you are absolutely right that Dr. Patterson, while talking with me yesterday, he said that don't take the vaccine because you're going to trigger the same mechanism that the virus causes to those who have already taken or who had already become infected. But I think the most important thing here is to notice that his message was mostly for long haulers, because those who were infected and have recovered, they are actually being exposed to virus again. Nowadays, the virus is everywhere and they are fine. So again, it is your choice. It is your decision. I feel, I'm going to give you my personal opinion now. If you are a healthy individual who got the infection and have recovered, your body has handled it before fine. So you don't need the vaccine to allow your body to be trained even more. The actual evil character had come in and trained your immune system already. However, if there are any immune system deficiencies that may be possible, or after your first infection, you had taken some medicines that may have modulated your immune system downwards, then it may be interesting and useful to take the vaccine once more, just to boost up the immune system. And I think I agree with Dr. Patterson that those who are long haulers may not need the vaccine. And I remember that last time when we were talking about Pfizer, I still remember I saw somewhere in that document about the long COVID. I could not search it when I tried to. So maybe I read it in some article, but I had that faint memory that they had said that it had helped the long haulers as well. So because I couldn't find it, so one, I apologize for that statement. Secondly, I still have to go find it to make sense of it. So let's start. So William Day has a question. Pfizer vaccine can spike 104 temperature. What to take to dampen the temperature without messing up the immunity? Normal anti-inflammatories, not anti-immune systems, but anti-inflammatory. Anti-inflammatory do not do anything to the immune system's function. They just reduce the outcome of the immune system, and the inflammatory markers that are being produced, they kind of suppress those markers. So ready? Let's start. So here's the document. And this document is in the description. I have the link in the description, plus the Moderna's design and the experiment. So this is the link as well, in which Moderna had used fetal tissue for the design part of the vaccine. And of course, this is drbeen.com. So if you wanted to take advantage of the year-end sale, you can actually go here and check discounted plans. Let's start. So this is the FDA's brief. There is a lot of data here. I'm going to go point by point. I have highlighted them. So first of all, this is the part of the executive summary. And they're saying over here is that there are 2 doses of the vaccine, 100 microgram each, given at 1 month's interval. The phase 3 randomized, double-blinded, and placebo-controlled trial, so there were 30,400 participants in it. The primary endpoint, so this is important to kind of note, the primary efficacy endpoint is the reduction of incidence of COVID-19. So they wanted to see if they can block the COVID-19 altogether or reduce the incidence. Incidence means the rate of occurrence of a disease in a population. And they compared the rate of occurrence of the disease in vaccinated group versus the placebo group. The secondary endpoints were avoidance of the severe COVID-19 and so on, avoidance of death from COVID-19. So the efficacy in preventing confirmed COVID-19 occurring at least 14 days after the second dose. So this is the second part. And if I can just very quickly draw it here. So what would happen is, so let's say this is the day 0, first injection, first dose, then a month apart, 1 month, 28 days or so, second dose, and then 14 days after that is when they start the clock to start measuring. So this much of the time, this 1 month and then this 14 days are not included. If somebody develops COVID during this time, who is even vaccinated, they are not included as the case occurring after the vaccination. The occurrence starts from here. So again, the rationale is very similar to the Pfizer one, that the immune system needs this much of a time and a booster in between to become totally robust against the vaccine, SARS-CoV-2, and then they start measuring from here. So Wayne says 44 days, yes. So 28 days here plus 14 days more, or let's say month and 14, so about 44 days. Now, this is an interesting point over here. So look at the efficacy, 94.5%, which is fine. We have talked about it before as well. One more thing, when you're looking at the data, the 95% confidence interval, 86.5% to 97.8%. That means that if we wanted to be confident that how would this efficacy look in 95% of the population, then the range that we are 95% confident is from 86.5% to 97.8% efficacy. Now with 5 COVID, this is an interesting one, 5 COVID cases in the vaccine group and 90 COVID cases in the placebo group. And I hear a lots of comments where people say that why even 5? This should be 0. And if it is 5, then I would just not take the vaccine. But look at this. There are two things. Number one, similar group, similar size and demographic group on the placebo side had 90 cases versus 5 cases here. So there is a significant difference between them, number one. And number two, all deaths that occurred on the placebo side. And they still say that there is possibility of 1 death being added on this side. So even the severity and then severity going towards the death is 0 with vaccination. Then they say here subgroup analysis. That means females versus males, whites, blacks, Hispanics, and so on. People with HIV, people with chronic diseases. So these are subgroups, various age groups. So subgroup analysis shows almost similar efficacy across them as well. But we would look at it that there are some groups where the efficacy is less or more, but that is not too less or too much more. Secondary efficacy analysis. So secondary was severe COVID cases, benefit of the vaccine in preventing severe COVID-19 cases, 11 protocol defined. Protocol defined means in this protocol, how do they define the severe case? And the definition will come up. COVID-19 cases in the placebo group versus the vaccine group. 0 cases in vaccine, severe, 0 severe cases in vaccine, and 11 in placebo. So again, this is a good outcome. Efficacy data from the final scheduled analysis of the primary. So there are interim analysis. So as they are collecting the data, and when they have enough people's data 2 months after their second dose, then they can come back and say, do an interim analysis, see if we are even making a difference at all or not. So we had talked about their interim analysis before. Then the final data is when they actually take all that data that has come in with 2 months efficacy point and then present that. So that data in this document will be called final scheduled analysis of the primary efficacy endpoint. So if you see here that data cutoff of November 21 with the median follow-up of this. So, but look at this, 94.1% efficacy. So that is a great efficacy. The vaccine efficacy in this analysis, when stratified by age group, so at various age groups, was 95.6% for 18 to 65. So 18 to 65 years of age, there for them the efficacy was 95.6%. And then 86.4% for participants greater than 65 years of age. This is different from Pfizer. Pfizer actually had a very high efficacy for people greater than 65 years of age. I believe their efficacy was 95% or 94 point something, and 1% low or 2% low in the higher age group. A final secondary efficacy analysis also supported efficacy against protocol, 30 cases in the placebo, so severe cases, final data, not interim data, 30 cases in placebo of severe, 0 cases in vaccine of severe. So I would always take the vaccine to make sure, and again, there is no guarantees for the life, but at least from COVID's point of view, I would take the vaccine to make sure that if I become sick, I don't become severe, or the chances of death from COVID are 0. And that is something that Moderna is showing. The most common solicited adverse reaction with mRNA injection was a pain at the site of injection. 91% of the people, so almost everyone, will have pain at the site of injection. Fatigue was about 68.5%. And please remember, other than the pain could last for a longer number of days. Most of the other ones, fatigues or headaches or myalgias, would subside within 2-3 days. Fatigue was 68.5%, headache 63%, muscle pains 59.6%, joint pain 44.8%, and chills 43.4%. So there are going to be, at least there is going to be pain, and after that there's going to be fatigue. Interestingly, if you can see, fever is not in this list. Severe adverse reactions occurred in 0.2 to 9.7 of participants, were more frequent after dose 2 than dose 1. And that makes sense because after dose 1, the body has started gearing up to understand that spike protein and attack it. And when you give the second dose, the body already knows a little bit of it and it's going to try to attack it. So the immune reaction is going to be more. I also want to make a comment over here. Somebody had left a comment on the previous vaccine discussions, and they had said that the pain at the site of injection is a proof that our immune system is getting damaged. So that is not a correct or a scientific reasoning. Pain at the site of injection is for two reasons. Number one, you have injected something in a muscle. So muscle is going to protest about it, and some cells are going to be stretched and skewed, and they would have pain. Secondly, you are eliciting a local immune reaction over there. So immune cells are going to come in, inflammation is going to happen, and that is going to cause pain. This is an indication of immune system working, not immune system becoming damaged. It is very similar to other infections that we get, or if we get an injury and there is a pain when the inflammation starts. It is not a sign of immune system getting damaged. And our immune system is not this weak that you give an injection and just that pain tells that the immune system has become damaged. The other interesting thing that I wanted to see here was Bell's palsy and the anaphylactoid reactions. And they did talk about them, and they said no anaphylactoid reaction. Bell's palsy was similar in both groups and similar to the general population. So we look in that. I think that their rate was actually lesser than Pfizer. See, the another thing that was lymphadenopathy. Lymphadenopathy, the name, the term might sound scary, but basically it is nothing. What happens is, if I draw, so let's say this is a shoulder muscle, deltoid, and we have given, see, it is an oid, deltoid, so it looks like delta. So here we have injected the vaccine, correct? So what will happen is the neutrophils and the monocytes, not the monocytes, the macrophages, the neutrophils, other cells are going to pick up this antigen. And what they do is, especially macrophages and neutrophils, they would go through the lymphatics to the local lymph nodes. So the lymph nodes that are in the axilla, they are going to run to those nearby lymph nodes and present the antigen over there and say, look what I brought. And what would happen is that the B cells and the T cells that live in these lymph nodes, think of these lymph nodes as laboratories, just like we have laboratories. So over here, the researchers are sitting, and these researchers are T cells and B cells. So the macrophages bring in the antigen. So the policeman captures the someone who is bad and brings them into this lab, and they say, hey, look what I brought. And so the cells here, they start replicating, they start increasing in number because they know we are going to become trained and we're going to have to take care of this thing if it is still there or if it comes in the future. That causes the lymph node to swell up. And the problem is that the lymph node has a tight capsule on it. So it is not very flexible in expansion. It has a capsule on this. So because of that tight capsule, when the tissue inside swells up, it causes pain, plus you can feel a swollen lymph node. This is what is called lymphadenopathy. Nothing special. With infections, it does happen. So here we are actually causing an artificial infection, if you will. I'm using the term infection a little loosely. So lymphadenopathy was another common adverse effect. Then There was no anaphylactic or severe hypersensitivity reaction with close temporal relation to the vaccine. What are they saying? Temporal means time. So they're saying as soon as the vaccine is given and within the time normally when the anaphylactic reaction occurs, there was no such incidence at all. So that is a great thing. Throughout the safety follow-up period to date, there were 3 reports of facial paralysis, Bell's palsy. So 3 reports in the vaccine group and 1 in the placebo group. So 3 versus 1. Currently available information is insufficient to determine a causal relationship with the vaccine. There were no other notable things. So no, what is that? Anaphylaxis, 3 cases of Bell's palsy, and then also there was no spinal cord injuries or spinal cord, I forgot the name of that disease. So that had occurred in UK with the other vaccines. So there was no such thing. So they say over here, there were no other notable patterns on or numerical imbalances between treatment group of specific categories or adverse events, including other neurological, neuroinflammatory, or thrombotic events. So this is a very good thing as well. Now, the severe or systemic adverse effect, that means headache or myalgia or arthralgia, the most common side effect in the placebo arm, which was numerically higher than the vaccine arm, was pneumonia and pulmonary embolism. And the most common side effect in the vaccine arm, which were numerically higher but not significant, were myocardial infarction, cholecystitis, and nephrolithiasis. So they're just reporting that there were some other diseases too that they observed, and some of them happened more on the vaccine side and some of them happened more on placebo. There did not seem to be a causal relationship to vaccine. So with this, now let's continue our discussion. This is the basic executive summary. Here, so this is what I wanted to share with you, that why are they not approving something like ivermectin or hydroxychloroquine or some combination of these drugs or a cocktail of these drugs? Here is the reason why they do this. Check this out. They're saying alternatives for prevention of COVID-19. This is FDA saying, is there an alternative? They're talking with people and they're saying no vaccine or other medical product is FDA approved for prevention of COVID-19. So imagine for a second, if they had approved ivermectin, they would never be able to say over here that there exists nothing else. And they would have to then say a vaccine is not needed. So they have to, by their intention of making the vaccine approved, they have to not look at the others. So this is one. And then even if you then say, well, they just approved Pfizer-BioNTech. Once again, they did not approve it. They give it an emergency use authorization, and emergency use authorization does not count. They could have given EUA for ivermectin, which they did not give. So then they talk about Remdesivir is approved, but Remdesivir is only in the severe cases, which I actually don't agree with that. Thus, there is, look at the last sentence here. Thus, there is currently no adequate, approved, and available alternative for prevention of COVID-19. These are the bases on which they are approving these things. So when we raise noise and we say, go ahead and approve ivermectin, they would not do it because then they cannot take the vaccine side. So I thought that was interesting. We saw that in the previous document as well. So then phase 3 follow-up. Adverse events considered plausibly linked to vaccine generally start within 6 weeks of vaccine receipt. So they are now talking about those adverse effects that are related to vaccine. Therefore, a 2-month follow-up period is necessary. So they're saying, why are we having a cutoff point of 2 months? That is because most of the vaccine-related adverse reactions would start occurring after the immune system has built up, and it takes up to 6 weeks. So that is why 2 months efficacy period is necessary. Vaccine composition. So this is important. What is in the vaccine? So please notice there is no fetal tissue in this one. And there is no fetal tissue in any. but there is no here. The Moderna COVID-19 vaccine is a white to off-white, sterile, preservative-free, frozen suspension for intramuscular injection. The vaccine contains a synthetic messenger ribonucleic acid, so it has the messenger RNA, encoding the pre-fusion stabilized spike protein of the SARS-CoV-2. The vaccine also contains the following ingredients: lipids. So these are what are going to make the lipid nanoparticle. So lipid and various kind of lipids that are part of it are listed here. Cholesterol is part of them as well. And then tromethamine hydrochloride, acetic acid, sodium acetate, and sucrose. So some salts as well. So lipids, messenger RNA, some salts for stability and for preventing vaccine molecules conjugating with each other when they're frozen. There is no preservative either. Then the temperature, minus 25 degree to 15 degrees centigrade, so minus 13 to 5 degree Fahrenheit. Multi-dose vials containing 10 doses are given. The vaccine must be thawed prior to administration. So before you give it, you take it out of the freezer and you thaw it. After thawing, a maximum of 10 doses, 0.5 milliliter each, 0.5 is a small dose, can be withdrawn from each vial. Vials can be stored refrigerated between 2 to 8 degrees centigrade for up to 30 days. Prior to first use, unopened vials must be stored between 8 to 25 degrees for up to 12 hours. After the first dose has been withdrawn, check this one out, the vial should be held between 2 to 25 degrees centigrade and discarded after 6 hours. So if it is not used after taking first dose out, then it has to be thrown away. We talked about the dosage, 100 microgram. Now they are starting to present the data. So again, we're going to look at various data points for various group types and what is the outcome. So the data grouping, one group was people of age 18 to 65, lesser than 65, and not at risk of progressing to severe COVID. So that these are those healthy individuals who do not have any comorbidity. For example, somebody is 30 years of age and has type 1 diabetes mellitus would actually not be in this group because they have a comorbidity that predisposes them towards severity. 18 to lesser than 65 years of age and at risk of progressing to severe COVID. So this is the second group. And then the third group is everyone greater than or equal to 65 years of age. So these were the three primary age groups. And this is important. The later two groups, that is people greater than 65 years of age, 65 and 65, greater than 65, and people who are from 18 to 65 but have comorbidities. This group was made up of 41% of the participants. So it is a significant group size. Participants were considered at risk for progression to severe COVID-19 if they had underlying comorbidities, including, so what are the comorbidities? Diabetes, chronic lung disease, obesity, severe obesity, significant cardiovascular disease, significant or liver disease, or infection with HIV. What is missing in here is autoimmune disorders. And I think the reason it is missing, and now I'm trying to interpret them, so I may be wrong. The reason that they're missing is because they did not think that autoimmune diseases is a comorbidity that should be looked at as a contraindication or indication for the vaccine. That is why they did not include that. The study included 24,907 participants considered at occupational risk. So this is also very important. 82% of the participants were those who were either, for example, healthcare workers or other essential workers who were supposed to be at the high risk. So their exposures were more, and I feel bad about the placebo group, and I thank them and salute them as well, that they were in the placebo group. They did not know they have gotten some water injected in them or the vaccine, and they were participating. So out of these 24,907, 7,613 or 25% were healthcare workers. So we've talked about the primary and secondary endpoints already. So for the primary efficacy endpoint, the case definition, what was the case definition, that what is it that would be called COVID? So that was two of the following symptoms: fever, chills, myalgia, headache, sore throat, new olfactory or taste disorders. So smell or taste. That any two of this group, or at least one of the following respiratory symptoms: cough, shortness of breath, difficulty in breathing, or clinical or radiological evidence of pneumonia. So one of this. And then nasal, so two of the top group, or one of the bottom, middle group, and one from the bottom. Nasal swab that says positive RT-PCR. So this was the definition of COVID-19 for them. The efficacy, so this is something that cool beans argue with me so much, that what do you mean by this is the efficacy? Efficacy should be all the people who got the vaccine, 100% would never get the COVID. And I think that is not what, they cannot wait for everyone to become exposed and then test them on daily basis to see if they got it or not. So all they do is, the efficacy's definition here is right in front of you. They would consider after a set number of cases to say how many occurred in placebo versus the vaccinated group. And that difference is the efficacy percentage. The final scheduled efficacy analysis of the primary endpoint was planned when the total of 151 adjudicated cases occurred. So this is where they had to stop, and they had to wait in both the groups for a collective 151 cases to occur, and then they could compare them and see, was there a significant difference in occurrence? So this is the secondary endpoint. So what is the definition of severe COVID-19? So here, severe COVID-19 is restrictive definition of a disease, which is down here, plus of course death is included in there as well. So here are the list of things that were included in it. You can read it. I want to continue towards the data itself. This is how they were following up. So if you got the vaccine today, so let's say this was if you were in trial, although you're going to get the vaccines outside of the trial if you decided to, or if your circumstances allowed you to, for example, you are in a healthcare setting or others. So injection day 1 and 29, then study visit. Of course, you come in on day 1 to get the injection, then you continue to come in for next 7 days or report for next 7 days if you have any symptoms. Then on day 29, you come in to get the injection, and then you continue to report the symptoms for up till day 36. Then day 57 is a follow-up, 209, 394, 759. So the follow-up would continue for a long period of time. Any symptoms of COVID-19 themselves were not supposed to be the side effects, because they would be indication of the disease has occurred. So this is the FDA's analysis, and again, their analysis is, it is fine. So I'm going to leave it. I want to show the data. So look at this. In this group, in this study, there were people who were SARS-CoV-2 positive before the study started. And then there were people whose status was not known, meaning they could not get this report that they were RT-PCR negative or positive. They just did not know. So there were some that were not known. So 5.7% in the vaccinated group were possibly already SARS-CoV-2 positive from before the vaccine. And similarly, 5.3% on the placebo side were also those who had the infection before. And you would see a little later that in the placebo group, at least one reinfection occurred, which is interesting for me to look at it this way, that out of total 15,210, there were 800 that had the previously that had infection. And out of 800, there was a case of one reinfection. Although out of this 800, there was no case of reinfection, but these were vaccinated. And then look at this as well, the death In the vaccinated group, 0. In the placebo group, 1. Demographics. So 47% females, 25.3% individuals greater than 65 years of age. 36.5% participants were considered as representing communities of color, with 9.7% African Americans. And you would see one thing interesting as I scroll through the data. You will see that all cases of infections occurred on the vaccinated side in the whites. They did not occur in the communities of color, although communities of color are actually more at risk than white, or Caucasian. But all the infections actually occurred in Caucasians. That was an interesting thing for me to see. Now, what are the comorbidities that they thought were important? Chronic lung diseases, significant cardiac diseases, severe obesity, diabetes, liver, and HIV. And so here is the data for various groups. So age, race. So in the race, if you see here, American Indians, Native, Asian, Black or African Americans, Native Hawaiian, Pacific Islanders, whites, and others. Ethnicity, Hispanics and Latinos, not Hispanic or Latinos. Race, non-Hispanic, and so on. So you can look at it. Interesting data here. I want to continue. This is also interesting that those who were participating in those, about 341 were known positive for previous SARS-CoV-2 infection. And in the placebo, there were 334 people who were known positive. So that is interesting. So look at this analysis. This is the overall analysis after the 14 days of the second dose. Overall, there were 5 cases of infections in vaccinated group. So the total number was 13,000, if you see here, 13,934. Out of 13,934 that were vaccinated, 5 people got the infection. And out of 13,883 who were not vaccinated, were in placebo, 90 became infected. So the infection rate in the vaccinated was 1.8%. And sorry, not percent, per thousand, 1.8 per thousand. And then on the placebo side, 33 per thousand. So that is a significant difference. So between 18 to 65, 5 people. So all these 5 who actually got COVID were all between 18 to 65. And then 75 on placebo side was 18 to 65. 65 years and older who were vaccinated, none of them got the COVID. And 65 years and older who were on placebo, 15 of them got COVID. This is significant. This is very important. That for the old age, somehow it seems like protection is more. So then they say there was an additional 18 cases which met the protocol-defined primary efficacy endpoint but were not able to be adjudicated in time for the interim analysis. So after the interim analysis, when they put all this data together, they are still following up, and they found 18 more cases who had infection. Of these 18 cases, 1 was in the vaccine group and 17 were in the placebo group. This ratio is very similar to the remaining data. Then the subgroup analysis, that means various ages, various comorbidities, and various ethnicities, various colors. And in general, vaccine efficacy among the subgroups are similar to the vaccine efficacy in the larger group. And so here they have data for all of them. Now check this out. This was interesting for me. They have given data for everyone. For example, females in the whole group, 3 females who were vaccinated had the infection. 2 males had the infection. On the placebo side, 45 females and 45 males got the infection. I would actually consider this 3 and 2 to be equal as well. But check this out. In race and ethnicity, non-Hispanic whites, 5. So all of these 5 people who actually became infected were all whites or Caucasian. Community of color, 0% out of 5,000 people, 0. On placebo side, out of 5,000, 20. So there is a significant difference here. Similarly, if you see here, Hispanics, 0, while on placebo, 12 Hispanics. Not Hispanics, white Caucasians, 5, on placebo, 77. And similarly, if you see here, American Indian, 0, Alaska Natives, Asians, 0, Black African or African American, 0, Native Hawaiian, 0, multiple racial profile, 0, white, 5. That is a very interesting one. So that means we should put this data in front of the placebo group as well and see what is happening there. So if you look at placebo group, over there, 80 Caucasian folks. And then if you see here, 3 Asians, 4 African Americans, 1 multiple also had the infection. If you look at this top over here, Hispanics or Latino, 12 in placebo group, and not Hispanics or Latinos, 77. So over there, the distribution is still more on Caucasian side, which in general, the number of infections are probably more on Caucasian side. That is correct. The severe cases are usually on the comorbidities or minorities. Here, the vaccine had kind of protected them all, except Caucasians had more infections. Now, I do not know if it was something to do with Caucasians or it was something to do with they felt that, hey, we are vaccinated, so the viral load was more, and I don't know. I can't say why this happened, but this was interesting data. Then if you see here in age group, all 5 who got infected on the vaccinated side were between 18 to 65, lesser than 65. They were all Caucasians, not Hispanic or Latinos. And at risk of severe COVID, one of them was at risk of severe COVID. That means they may have some comorbidity. 4 of them were not at risk of severe COVID. Compare that to placebo on this side, and you would see there is a different structure there. So only 2.2% of the participants had evidence of prior infection. So 2.2% of the participants had previously the SARS-CoV-2. And there was only 1 COVID-19 case starting 14 days after the second dose reported from this subgroup, which was in the placebo group. So what are they saying here? They're saying that there were 2.2% people who were SARS-CoV-2 positive before. Of course, half of them were, let's say, in the placebo and half were in the vaccination group. In the vaccination group, no reinfection occurred. In the placebo group, 1 reinfection occurred. And check this out. So this is again the same thing. SARS-CoV-2 positive, 341 on the vaccinated side, 0 got reinfected, 334 on placebo side, and 1 got reinfected. This is about the various comorbidities and their data. Again, very interesting data. Chronic lung diseases, 0 people who were vaccinated got any infection. On the other hand, 606 people out of 673 in placebo got the infection. Significant cardiac disease, again, 100% protection. Severe obesity, 1 case out of 900. And over there in the placebo side, 11 out of 884. This is very important. So if obesity is a comorbidity, I would recommend that you get the vaccine. Diabetes, 100% effective. Liver disease, 100% effective. HIV, 100% effective. And if you look at this, the number is small, but we have been looking at smaller studies as well. So 80 HIV positive patients were on vaccinated side, and none of them got the infection, and 76 were in placebo, and 1 of them got the infection. So 100% efficacy on the HIV infection side. Then severe COVID-19. This is also important. All 11 cases of severe COVID-19, at least 14 days after the second dose, as assessed by the committee, they all were in the placebo group. Of these 11 participants, 5 had risk factors for severe COVID, 6 did not. 3 severe COVID-19 cases resulted in hospitalization. So if you see here, 11 severe cases on placebo, 0 on this. But then they have this, I believe, one participant in the Moderna vaccinated group, greater than 65 years of age, had risk factors for severe COVID-19, was hospitalized due to oxygen saturation of 88% on room air 2 months after the second dose. There was a verbal report of the positive SARS-CoV-2. However, nasopharyngeal swab collected during hospital was negative. So there is one case that may be. There were 4 additional severe COVID-19 cases which met the protocol-defined severe cases COVID-19 endpoint, but were not able to be adjudicated in time for the interim analysis. All 4 cases were in the placebo group. So 11 adjudicated or reviewed cases in placebo, then 4 more have occurred which are not fully adjudicated, but they are also in placebo. This is a very important data point. Okay, so this is also very important. This is what happens after first dose. So let's say you took the first dose and you decided that, hey, I'm not going to go for the second dose. What happens? So after dose 1, people discontinued for whatever reason. After dose 1, there were 996 total participants after the first dose when they took this data. 7 of them had developed COVID. And then placebo group, there were about 1,079 and 39 of them got COVID. So this was about 80% efficacy. However, after dose 1 to 14 days after dose 1, that means from this dose 1 to 14 days here, within this time frame, 5 cases out of 996 occurred here, and 11 cases occurred there. So efficacy was only 50%. This was a similar efficacy for Pfizer as well. So the takeaway is dose 1 and then leaving it is not the right thing. Although greater than 40 days, so let's say you got the dose 1 and then you continued going, and we are continuing to see what is the situation. So after 14 days, 2 more cases got the infection, while on the placebo side, 28. So this was 92% efficacy, which if I hypothesize that why this happened, after the first dose, immune system is still getting ready to respond. And we know that antibody formation is going to occur somewhere after 14 days, anyways from 7 days to 14 days. So if you are counting before 7 days, we do not know if the B cells have become ready and T cells have become ready. So the chances of infection are more. But after 7 days and onwards, and let's say window from 7 to 14 days window, if you leave this window alone, this is a time when immune system is ramping up. Then from here onwards, immune system should have better preparation. So that is what is shown here, 92% efficacy. So on one end, I'm kind of saying don't go away after the first dose. But after the first dose, after 14 days of the first dose, then the efficacy is 92%. So that I thought was a very interesting data point. Here is one more thing: vaccine efficacy of to prevent severe cases. So number of participants with severe COVID-19. Vaccine group, this is after dose 1. So this is the dose 1. So dose 1, this is dose 2. So there, somebody took the dose 1 and now they're looking at severe cases. So 2 severe cases after dose 1 versus 4 severe cases after dose 1 in placebo. So only 42% efficacy. So once again, will I recommend dose 1 and then leave? No, because the severity is not curtailed. That is dangerous. So then this is the starting 14 days after the second dose. All participants, so this is similar thing as we saw before, so I'm not going to go into this again. This is severe cases. Then more data on the severe cases and each death that occurred. So there were additional 19 cases of severe COVID, which resulted in one death as well, but that happened in the placebo group. So they have now discussed that all of the deaths that occur, what were the reasons, and that data is here. So if you see here, severe cases 14 days after dose 2 based on adjudicated, 0 here and 30 there. So this is after the interim data. This is the final data. And they are seeing 0 severe cases on the vaccine side versus 30 severe cases on the placebo side. So here they make this point as well, that the efficacy observed after dose 1 is not sufficient to say that just dose 1 is sufficient. And then is the, are you holding up fine? I'm talking a lots of data points here. Are you still here? Or am I just talking with myself? So there are folks here. So, so this is the adverse reaction. So I wanted to discuss the adverse reactions as well. So if you can hold out a little more. I'm going to leave this. This is the adverse reaction between the vaccine, those who had the vaccine, who were positive before and then who were not positive before. So there is not much difference between them. So that means if you were positive and you got the vaccine, there is no injurious effect of the vaccine. So I'm going to go here. This is the local adverse reactions. So the local adverse reaction, so where we injected 84%, the proportion of participant reporting any local adverse reaction was 84% and 88% after dose 1 and 2, compared to 19.8 and 18.8 after dose 1 and 2 of the placebo. So in their placebo was much more benign compared to the placebo given for Pfizer, because their placebo was a vaccine as well, meningitis vaccine. So very few adverse reactions on the placebo side, but they were more on this vaccine side, and they're not dangerous. There was no anaphylactic reaction. So look at this. The most common was pain, 83% versus 19% in the placebo. So it was not just the injection, it was the vaccine getting in the tissue, causing immune system to react, making local inflammation, causing pain. What they have done, and I really loved this, for every adverse reaction, they have given the duration that was observed and the age group in which it was observed. So folks with the advanced age, 65 and over, actually they had very few adverse reactions. So pain, look at this. I'm just going to read pain, and then every other adverse reaction is structured in the same way. So for pain, for example, they're saying 83.7% in vaccinated, 19.8% in placebo after the first dose, and then they have 88.4% in vaccinated and 17% in placebo after the second dose. Then they say the median duration for pain were 2 days and 3 days after dose 1 and dose 2. So the pain occurred for 2 days after dose 1 and 3 days after dose 2 median. So that means some people may had 7, some people may had 2, but the median was 2 days. The highest rate of pain were in participants 18 to 64 years after the dose 2. So that means almost 90% of the people who are in this age bracket after second dose will have pain for at least a couple of days. So they have then addressed the same way all other lymphadenopathy, 10% versus 4.8%, that would stay for a couple of days, and then the age group is 18 to 64 as well. And then they just continue and they provide all of this data as well. Nothing jumped out over here other than there would be pain, and it is possible that lymph nodes will swell up. What are other things? Erythema or redness, swelling, and lymphadenopathy. Systemic adverse reactions, for example, body aches or fatigue or headaches or nausea, vomiting, such things. So what about that? So reporting any grade, so let's actually go to the data. Fatigue was the most frequent. Just like in the local reaction, pain was the most frequent. In the systemic reaction, fatigue was the most frequent. Reported by 68.5% of the recipients in the vaccinated group and 36% in the placebo, which is interesting for me, that placebo group, 36% people complained of fatigue after the vaccine. And then the median duration of fatigue for the vaccine was 2 days. So 2 days pain and 2 days fatigue. The highest rate of fatigue were reported in participant 18 to 64 years of age. After the second dose, with 66.7% reporting any fatigue, 10.6% repeating grade 3, and 1. So again, this relatively younger age group had fatigue, couple of days is the median range. Headache was the second most common, 63%, and then they have given the same data for headache as well. Then was fever. So fever is not the first one. So fever was 14.8% in the vaccinated and 0.6% in placebo. So that is very interesting. Then I want to continue on. So there is more data, but these data points are more interesting. Unsolicited adverse events. So those that they were not asking for, but the patient said, hey, I have this as well. So what were these? If you see here, there were some patients who developed infections. Some developed vascular disorders. And if you see here, any severe, any in placebo and others. So if you see, for example, 3.4% developed infections. And in the placebo, 4% developed infections. So almost similar. Vascular disorders, 1% developed vascular disorders, placebo 0.9%, so almost the same. Nervous system disorders, so we are a little bit more hesitant from vaccine because there may be some issue with the spinal cord and the nervous system. So if you see here, nervous system disorders, 4.1% on the vaccine side and 3.6% on placebo, so almost similar. Then cough and oropharyngeal pain and diarrhea and skin rashes and those things, 1.4% had rashes and 1% in placebo. Musculoskeletal issues, arthralgias, myalgias, if you see compared to placebo, they are similar. So to me, they do not seem to be related to the vaccine. Then immediate adverse reaction. So this is anaphylaxis, that you give the injection and soon after that there is an anaphylactoid or anaphylactic reaction. So there was nothing observed. So if you see here, review of unsolicited after effect that occurred within 30 minutes of vaccination demonstrated comparable rates 0.6, 0.6, and none of the events reported in the vaccine group were considered serious. So that may be, hey, I have pain or I'm feeling headache or something like that. There were some people who had withdrawn from the study as well. There were deaths as well. So as of December 3, 13 deaths were reported, 6 in vaccine group, 7 in placebo. But again, the vaccine group deaths were not COVID related. So they have given every death's data here. 2 deaths in the vaccine group were in participant greater than 75 years of age with pre-existing cardiac disease. 1 died of cardiopulmonary arrest 20 days after dose 1. One participant died of myocardial infarction 45 days after dose 2. Another 2 vaccine recipients were found deceased at home, and the cause of these deaths is uncertain. So they have actually given the causes for placebo and for vaccine as well. So I want to now go to, this is an interesting one that we did not see with Pfizer. That some folks who have, for example, the cosmetic injections, they developed inflammation at the site of the cosmetic treatment. So that was interesting. And this one person developed lip angioedema. So that means their lips became swollen. But she said that she develops this with flu vaccine as well. So there was maybe a local reaction there. But that was interesting because they say that they observed that people with the cosmetic injections had inflammation around those injection areas, which subsided, but that was an interesting extra side effect. Then pregnancies. So once again, they were ruling out anyone who is pregnant could not get the vaccine, but there were people who became pregnant during the vaccination trial. So 13 pregnancies were reported through December 2, 6 in the vaccine group, 7 in placebo. And if you see down here, unsolicited after effects related to pregnancy included a case of spontaneous abortion and a case of elective abortion, both in the placebo group. And they say the 6 who are pregnant on the vaccine side, they do not have data for them yet. Then we are almost at the end, so please hold out a little more. There are some questions that they have answered. So unknowns, benefits or data gaps, some things that they cannot really talk about. One is the effectiveness in certain population at high risk. Although the proportion of participants at high risk of severe COVID-19 is adequate for overall evaluation of safety in the available follow-up period, the subset of certain groups such as immunocompromised, this is what I was saying, they did not have much data. Individuals, for example, with HIV/AIDS are too small to evaluate efficacy. Effectiveness in individuals previously infected with SARS-CoV-2. So they say limited data suggests that individuals with prior SARS-CoV-2 infection can be at risk of COVID-19 reinfection and may benefit from the vaccine. So we saw that on placebo side, there was one reinfection out of 800. And then on the vaccine side, there was no reinfection out of a similar number. Pediatrics or children, so they had not given the vaccine to younger than 17, so they do not know. Then vaccine against asymptomatic infection, meaning they've given the vaccine, but did people actually develop the infection and they were asymptomatic? And they are saying we do not have data for that. That is the same answer that Pfizer had. So vaccine effectiveness against long-term effect. So this is the long hauler. So this is that after giving the vaccine, will you become a long hauler or not? And they say we do not know yet because we haven't seen that data. Or will the vaccine protect from someone becoming a long hauler even if they become infected with COVID-19? And they're saying we don't have enough data. Vaccine effectiveness against SARS-CoV-2 transmission. That is, if I am vaccinated, will I still be able to transmit that? And they say we don't have enough data. So this is the discussion for today. I hope it made sense. What I wanted to do was I wanted to go over this document so that you feel encouraged as well to go read it, or you can actually find something that is of interest to you and look at it. So I wanted to go over the whole thing so you become familiar with it. So let's see if there are any questions and then we stop. So Margaret says, see Wayne's question. All right, I would look at that, Margaret. So let's see. Wayne, where is your question? Wayne, question. If you have a reaction to regular flu vaccination, will you likely to have a reaction to COVID? No. So what they observed was one person had lip lip angioedema or swelling of the lip after this vaccine, and they said she had the same thing after flu as well. That is an exception, and they are still trying to figure out why that happened, but they did not observe this in others. Now, they do not talk about this data that if you had reaction to flu, will you have reaction to this as well? So that specifically is not addressed here. So based on this data, I cannot answer this question. But I would not think that that should happen with this vaccine. The type of vaccines are different. Colin says, question, Dr. B, will individuals who suffered from COVID-19 need a vaccine too? So that is what they talked about. There were 800 individuals who were, or 336 individuals who were COVID-19 positive before and got the vaccine, and there was nothing bad that happened to them. On the placebo side, there was a similar number that were COVID-19 positive before, and then one of them became reinfected as well. So that small data tells them that the reinfection is prevented with the vaccine. Any other questions? Cool. It seems like there is a question from Eric the dog. Does second dose have to be on exact date, hospital specify? So Eric, very good question. They do have example of some people who actually did not come back on the same date, and they were given vaccine a little later. But that number was so small that data is not significant. So I would say, excuse me, I was fine. I just started coughing. I would say that it should be on the same date so that you can get your immune system built up fast. But if you're coming in a little later, what I do not know is that during that time, will the effect of dose 1 reduce? Ideally, it should not. But that data doesn't say it. Excellent. So it looks like there are not more questions here. There is one more question. Shouldn't ivermectin be taken weekly rather than monthly for prophylaxis? I'm not going to talk about ivermectin in this discussion, Muhammad Zubair. So we should do that separately. So the cool bean number 381. If you think you had COVID in Feb, would your antibody be positive now? So we have done this discussion many times, that this is possible that in the beginning you have a higher titer, higher level of the antibody, then the antibody level drops. But if you get reinfected in a healthy individual, your antibody level will go up very fast. So there may be baseline antibody, and that should be there. I think so. I was fine. So Janet is talking about my cough. I was fine throughout the lecture, and then all of a sudden now I'm trying to see if there is something in the environment, some dust or something. Janet says, question, PEG adjuvant. I think they do not have any adjuvant. They say that the lipid nanoparticle itself is enough to be able to trigger the immune system. Janet says, define long hauler. So Janet, there is no specific definition so far, but the way I had been seeing long hauler is somebody who got the infection, recovered, became better, and then they got stuck in a cycle of headaches and cough, fever, fatigue, and various other things that Dr. Patterson talked about yesterday as well, and just coming and going, cycling, fibromyalgia, tiredness, psychologically upset, and so on. So there is a question from Melanie Goodman. Question, is this vaccine safe for people that suffer from type 4 hypersensitivity? So yes, so they say that they had not seen any hypersensitivity reactions. So now, did they have no severe reactive folks in that group? They don't talk about it, but they say we did not observe any hypersensitivity reaction. Mackay Smith says, the UK government has set up special software expecting millions of adverse reactions. Please, may you look into that and do a video regarding that. Absolutely. Can you give me some link? I would do some Googling as well. Janet says, Luffy, I think Luffy's going to kill me. Yes, with these allergies. Jana has a question about surgery. So let's see. So Jude says, can you recap the storage again? So why not we just go and look at it? I can't imagine we went through the whole document. Dr. Mubin, at your service. Here. The Moderna COVID-19 vaccine is provided as a frozen suspension stored between 25 to 15, minus 25 to minus 15 degrees centigrade, multi-dose vial containing 10 doses. The vaccine must be thawed prior to administration. After thawing, a maximum of 10 doses, 0.5 milliliter each, can be withdrawn from each vial. Vials can be stored refrigerated between 2 degree to 8 degrees centigrade for up to 30 days prior to the first use. However, if you have opened it, unopened vials may be stored between 8 to 25 degrees centigrade for up to 12 hours. After the first dose has been withdrawn, the vial should be held between 2 to 25 degrees centigrade and discarded after 6 hours. So that is, hopefully, that answers your question, Jude. Cool. So I think this is the discussion. Josh says, my grandmother is high risk and lives in a care home. She has a sulfa allergy. Should she get vaccine? Is having current allergies to drugs resulting in an increased risk to an anaphylactic reactions? So Josh, the data does not show it. So these specific cases will be something that the doctor will have to talk with the vaccine providers to say, can we do this? So far, data does not show this. AS says, I just got an MMR2 shot 1.5 weeks ago with no negative reactions and want to begin to take ivermectin 12 mg weekly as a prophylaxis. Starting it. So I'm trying to avoid the ivermectin questions, but no, it does not matter. Wayne says, can we reach herd immunity if only 50% of the population takes the vaccination? Yes. Well, let's look at it this way. Out of the 15,000 people who were given vaccine, 5 developed COVID, and even then not severe. So that means these 15, we can trust that they have antibodies. So in theory, the answer to your question is yes. If 50% or 60% of the population gets the vaccine, then we are at herd immunity if they have all become vaccinated correctly, immune correctly. Somebody became very upset with me yesterday for saying this, that if not everyone is going to get the vaccine, then some people are going to get vaccine and others will be safe. And they said, who are you to say that vaccine folks should protect the non-vaccine folks? So I can't get into those fights. But the thing is this, whoever gets a vaccine or becomes infected and recovers have become participant in herd immunity. Absolutely. Margaret has been very generously supporting my work for months now. So Margaret, I am very grateful as well for your support. So Josh, your question about the transmission, they both are saying we do not know. So we are waiting. Jim says, anyone concerned about shingles or allergies should be taking extra T3. Okay. Is this, Jim, is this a question or a comment? Last question. Does the vaccine contain preservatives like thimerosal? They say we do not. So let's see. You have the things here. I don't feel, see, it says preservative free frozen suspension. So I don't think that it has preservative. At least that is what FDA says here. So if you see here, preservative free frozen suspension. Cool. So, okay, one more question. If I had COVID in the past, is there a probability of showing positive in RT-PCR in the future? Very good question. And the base answer is that it depends upon the load in your throat. So your body may be able to take care of it. But if the virus is sitting here and then you take that from a swab, you might actually show RT-PCR positive. So this is a very important question. And some people ask me this way, that would you get the vaccine? And some people say, why don't you go get the vaccine first? So yes, I will get the vaccine. As soon as I'm given an opportunity, I will get the vaccine. And I was thinking that when I get the vaccine, I'm going to, if they allow me, I'm going to record myself and I'm going to post it. So Josh says, are there anaphylactic reactions to the vaccine happening minutes after injection or over the course of days? Should we carry epinephrine? At least in this one, they say there is no anaphylactic reaction soon after or no reported reaction as well. And they don't say no reported anaphylactic, they just say no reported severe adverse effect. I'm sure that if there was an anaphylactic reaction, they would have to document that. But if you are allergic and you carry epinephrine, then carry it. This is a good question. Jose says, Dr. Wayne, what vaccine would you prefer to take, Pfizer's or Moderna? So I think number one, we won't have a choice. Whatever is in our area is what we're going to get. I would prefer Moderna. Shahida says, can RT-PCR detect RNA of dead viruses? Yes. Makai says, don't feel pressure to get vaccine, please wait. That is totally fine. Thank you very much. I actually want to get vaccine. Very good. So this is the discussion for today. Let's see what happens tomorrow in terms of the approvals, and we'll go from there. Please like, subscribe, and share. And if you wanted to support my work, if you like it, there is a link in the description to support my work. Thank you very much. See you tomorrow.